Let's talk about what an ABI is and the importance of an ABI, excuse me, when we're assessing the diabetic at-risk foot. So just palpating pulses isn't good enough. I see that a lot in our charting, palpable pulses. And, don't be fooled by palpable pulses alone. In fact, a study showed that 52% of patients with palpable pulses, we were actually palpating our own pulse. And then another study showed that even with an ABI, the ankle-brachial index, patients that had palpable pulses had a low ABI. So don't be fooled by palpable pulses. Get some screening studies, ABI, and then I also would advocate for a TBI as well. So again, the ABI is ankle-brachial index. You take the blood pressure of the arm and then around the ankle, and you make the calculation. And you can see that between 1 and 1.4 is normal. Sometimes patients with diabetes will have hardening of the arteries, and therefore their ABI will be falsely elevated. So when you get an ABI in a diabetic patient that's 1.4 or higher, don't be fooled by that. It doesn't mean they have really good blood flow. It actually means that their vessels are calcified. So we're getting an abnormal elevated ABI. Acceptable range 0.9 to 1, mild peripheral arterial disease 0.8 to 0.9, moderate 0.5 to 0.8. And this is where I start to get vascular involved, at least for a second opinion, to see if there's any way we can optimize or increase blood flow. And then anything below 0.5 is severe, that's critical limb ischemia. So toe brachial indices I find a bit more helpful in our diabetic patients. Again, we talked about that there's calcification of the vessels, the large vessels in the leg, and it could show us a falsely elevated ABI. Not only could it be falsely elevated to the point of 1.4 or greater, it could actually be falsely elevated in when there is peripheral arterial disease. So it can make us think we have a good ABI or good blood flow. And then in some rare cases, I shouldn't say rare, in some cases, we can get back a report that says the vessels are non-compressible. I'm sure you guys have always had all experienced that. And so when you send a patient for an ABI and it comes back non-compressible, that means that their calcified vessels couldn't be compressed, so they couldn't calculate an ABI. So that's why I advocate for not only an ABI, but also a TBI, so a toe brachial index. You'll see that although the patients do have microvascular disease and some calcifications in the small vessels of the foot, the toe brachial index is probably a better test, a better screener for what blood flow is distal to the ankle. And obviously with diabetic foot ulcers, that's where the problem is. So a TBI of 0.5 to 0.75 or greater is good. That means they have that distal blood flow, and they should have a decreased propensity of skin breakdown. And then also, if they should develop a diabetic foot ulcer, they have a good chance of healing that ulcer because they have adequate blood flow.